Now we're going to shift gears from the female reproductive system disorders to the male reproductive system disorders, and the most important one we're going to discuss is benign prostatic hyperplasia, BPH. First, let me define the term hyperplasia. Hyperplasia. This is one of the adaptation mechanisms by which the cells adapt to stress. Hyperplasia means your cells increase in number. Your cells increase in number. So it is benign prostatic hyperplasia and not benign prostatic hypertrophy. Yes, the prostate gets bigger, not because its cells get bigger, but because its cells get more. So let's talk first about some anatomy and physiology of the prostate gland. The prostate gland in males lie below the bladder surrounding the urethra. And the prostate is made of three types of tissues. The glandular epithelial tissue, and this is the tissue that is stimulated by androgens, testosterone, and also we have stromal tissue, supportive tissue, made mainly of smooth muscles, and these smooth muscles are rich in alpha-1 adrenergic receptors, hence they will be stimulated by norepinephrine. And finally we have the capsule of the prostate, which is a fibrous tissue and smooth muscle tissue, again rich in alpha-1 receptors, again stimulated by norepinephrine. The normal ratio of the stromal to epithelial tissue in a normal prostate is 2:1. In BPH, guess what? The stromal tissue increases much more than the epithelial tissue. So the ratio is 5:1 in BPH. This means what? Too much increase in the stromal tissue, too much increase in the alpha-1 receptors. This will make very good response to alpha blockers, and hence alpha blockers are the best symptomatic medications for BPH symptoms. BPH, when the prostate gets bigger, how can the prostate get bigger? Normally, testosterone is converted by the enzyme 5-alpha-reductase into the active metabolite dihydrotestosterone, or DHT. DHT will induce the growth and enlargement of the gland. And when the gland gets bigger, we get the symptoms due to two factors. Static factors. The mere anatomic enlargement of the gland is going to compress the urethra that passes through the prostate gland. When your prostate gets bigger, it's going to compress this tiny urethra, making the urethra narrower, and hence you get symptoms. And this are called static factors. But also we have a dynamic factor involved here, and this is related to the excessive alpha-adrenergic tone of the stromal tissue and the capsule of the prostate, as well as the bladder, neck, and urethra. So the capsule and the stromal tissue in the prostate becomes more active, and the prostate becomes kind of contracting and constricting the urethra. Again, these are dynamic factors. Both of them will lead to the lower urinary tract symptoms, or what we call LUTS, and they will result from either static and or dynamic factors. So the symptoms will occur mainly because of urethral obstruction. So you get weak stream, poor emptying and dribbling, and post-voiding dribbling. And because of this, urine is going to kind of accumulate in the bladder. Because of the urethral obstruction, your bladder has to do more effort to push urine through the narrowed urethra. So finally your bladder will become thickened and irritated, and this will lead to frequent urination, urgency, I have to go to the restroom right now, and nighttime urination, nocturia. So the enlarged prostate will lead to urethral symptoms, weak stream, poor emptying, dribbling, and bladder symptoms, frequency, urgency, nocturia, frequency, urgency, nocturia. These are the manifestations of BPH. How are we going to manage? Well, we have these 7 steps of managing BPH. Number 1 is watchful waiting. If the patient's symptoms are not so bothering, and if the gland size was not too big, then all what you need to do is just advise lifestyle modification and monitor the size of the prostate by digital rectal exam, by prostatic specific antigen, by ultrasound testing, just watchful waiting. If the patient is symptomatic, the best symptomatic management is to give alpha blockers. Why? Alpha blockers relax the alpha receptors. Alpha blockers work fast. Within a week or two, the patient is going to be free of symptoms. How nice. But alpha blockers will not affect the size of the gland. What can shrink the gland? It's the 5-alpha reductase inhibitors. These will shrink the prostate, will make the prostate get smaller, and these are mainly indicated for big-sized prostate. But the point here is they take long time. They take long time. And that's why they will not be effective in the fast reduction of symptoms. And that's why sometimes we have to use combination therapy. If the patient has big gland and too much symptoms, the patient cannot stay for 1 year having these symptoms. So you have to give this patient something for the symptoms, that's the alpha blockers, and something for the size, that's the 5-alpha reductase inhibitor, and this is the combination therapy. When are we going to use phosphodiesterase inhibitors for prostate? Only when it is associated with erectile dysfunction. And when you have too much bladder irritation, too much frequency, too much urgency, too much nocturia, this means your bladder has become so irritated that it needs to be relaxed, and this is the time for adding an anticholinergic agent. When are we going to think of surgical treatment? When we get complications. When we get complications. What are the complications? I'm going to skip this slide and then come back to it again. What are the serious complications of BPH? Retention of urine, surgery. Hematuria, surgery. Overflow urinary incontinence, surgery. Recurrent UTIs, bladder stones, chronic renal failure, all these are indications for surgery. So for the watchful monitoring, you advise the patient for and by the way, what's healthy for your heart is also healthy for your prostate. So advise a heart healthy lifestyle. And some herbs like saw palmetto, although there is no evidence base for that, but is very commonly used for the prostatic symptoms. So this diagram summarizes the management of BPH. Mild symptoms, watchful waiting. Severe symptoms or complication of BPH, surgery. Most of our patients will have this intermediate category of moderate symptoms. Moderate symptoms in a small gland, give something to relax the gland. Alpha-adrenergic antagonists or alpha blockers. Large prostate, large gland and symptoms, give something for the symptoms. Alpha blockers, give something for the big size, give 5-alpha reductase inhibitors. Erectile dysfunction, add phosphodiesterase inhibitors. Irritative bladder symptoms, give anticholinergic. One final question. What if the gland is big but the patient is not bothered by the symptoms? So the patient is not complaining of symptoms, but you examine the patient and you realize that the gland is big. Now you should be concerned and you should prescribe for this patient what? 5-alpha reductase inhibitor to shrink the gland. And here there is no need to give alpha blockers because the patient is not bothered by the symptoms. So let's talk about the medication. Let's talk about the alpha-adrenergic antagonists. Alpha-adrenergic antagonists. We have what's called the second generation of alpha blockers because the first generation is no longer used. So prazosin, terazosin, doxazosin, these are the second generation alpha blockers, and these work not only on the alpha receptors in your prostate but also on the alpha receptors in your blood vessels. So when you take them, all your blood vessels will dilate and you can get orthostatic hypotension and syncope, and this usually used to happen with the first dose, and this led to what's known as the first dose syndrome or first dose syncope, and that's why we used to start with a very low dose and we advise the patient to take this dose at bedtime and not to get out of bed after they have taken the medication. But now we have the third generation uroselective that will only work on your prostate, not on your blood vessels, and will not cause orthostatic hypotension. The famous tamsulosin or Flomax, and another drug less commonly used which is silodosin, but famous tamsulosin is the alpha blocker of choice for BPH. And these are selective. This will not cause hypotension. The 5-alpha reductase inhibitors, as I said, they inhibit the enzyme that activates testosterone, and this will lead, when you inhibit this enzyme, the prostate size is going to shrink, and when the prostate gets smaller, less compression on the urethra, less urethral manifestations. And the famous example is finasteride Proscar. Finasteride Proscar, which is a selective inhibitor of this 5-alpha reductase found in the prostate, is the 5-alpha reductase inhibitor of choice for prostate patients. And the combination therapy is whenever you have big sized gland and severe symptoms, because these drugs take 6 months to 1 year to shrink the prostate. So let me summarize, how do we manage BPH? How do we manage BPH? This diagram illustrates on its x-axis the symptom severity, and on the y-axis the prostate size. So when are you going to do watchful waiting? When the symptoms are not bothering and when the size is small, so small gland and not severe symptoms, just watchful waiting. What if the patient has very severe symptoms, or the patient is bothered by the symptoms but the prostate size is small? This is the quadrant 4 alpha blocker. When are you going to consider 5-alpha reductase inhibitor? If the patient has no bothering symptoms but the gland is big. When the gland is big, you have to shrink the gland, so you're going to consider 5-alpha reductase inhibitors. When are you going to use combination therapy? When the gland is big and the symptoms are bothering.